Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
Welcome back to The Summary Podcast. I'm your host, Doug Henry.
And I'm Dr. Yunna Sinskey.
Today, we want to go over care of those patients with amputations. We have an expert joining us, and of course, Yunna just completed a amputee fellowship, so she's also an expert. I am very much not an expert. I see a kid with an amputation about every couple of years, so I think I'm like a lot of physicians and physiatrists who never see people with amputations or see very few and just don't keep up on that. So it's going to be helpful for me, and I think a lot of our listeners to kind of get caught up on this.
Mm-hmm. And that's also because I steal all your pediatric limb difference patients
Yeah,
away
now I'm not going to see any anymore. That's all right.
That's the goal. I'm going to just gather them to myself. All right. So we are today very thrilled to welcome Dr. Rebecca Speckman on the show. Dr. Speckman received her MD and PhD in epidemiology from Emory University, Atlanta. She also trained at University of Washington for PM&R residency and VA Puget Sound for amputation rehabilitation fellowship. So after serving as medical director of amputation rehab at VA Salt Lake City, she returned to VA Puget Sound, where she's a medical director of the Regional Amputation Center. She is also the assistant professor in Department of Rehab at University of Washington, UW, and also my former fellowship director of amputation rehab, joint with University of Washington and VA Puget Sound as well. All right. So, as you know, I love amputee care. I both see kids and adults. So this is my love and passion, and hoping that a lot of people get to see this podcast and say, man, I want to do amputee care too, and I want to do it right. So that was one of our main reasons for picking this topic. So Becky, not Dr. Speckman, thank you so much for joining us today. I think the biggest question, that first question that I was asked a lot when I was going into amputation rehabilitation is basically, what is the role of a physiatrist in basic amputee care? So what are your thoughts on that?
Great question. So as you've seen, when I give an intro talk on amputation rehab, I like to start off with the history of amputation rehab. And when I do that, I make the argument that it started in my hometown, Columbia, Missouri. But one of the early founders of rehabilitation medicine was Howard Rusk, and he developed his interest in rehab before our field existed by interactions he had with a gentleman who had lower limb amputation. This was the cook at his fraternity in college at University of Missouri. And so then he chose a path in medical school and in practice, and then serving during World War II, in which he developed interdisciplinary amputation and care and interdisciplinary care for brain injury, spinal cord injury for service members. And then after World War II, he helped develop the VA into an interdisciplinary rehab model for all of these different diagnoses, and also worked on spreading that model in civilian care. So he wrote this fantastic paper in JAMA in the 40s. It was the argument for, why do you need to have physicians involved in rehabilitation? And he went through all of what we now think of as the core diagnoses. So amputation, spinal cord injury, brain injury, orthopedic injuries. And a lot of the arguments for each of it boils down to, you need a physician who understands the different elements of rehabilitation and who thinks of the patient through the rehabilitation lens in order to pull the right elements together. So really to create and help lead the interdisciplinary team, and then to kind of take a step back from all the medical complexity that might be going on, and say, okay, if the patient's goal is to walk or to otherwise restore function, or they've got other goals that they've never done before, how do we best accomplish those goals? And I also think of part of our role is to know the questions that other members of the clinical team should ask but don't know to ask, or that patients don't know to ask. So if I'm taking care of a patient on an inpatient unit and they have a potential cardiac diagnosis, I'm not sure what to do, I consult cardiology, I might not ask them the right question. Yeah, I'll probably be lucky if I ask the right question to them. I want them to look at this patient and say, is there a problem in the cardiac realm? And if they tell me there's not, that'll be helpful. But more often than not, they'll identify the problem better than I did and think of other things as well that would be helpful for the patient.
Yeah, I think that's a fantastic point. Just in general, you can ask a patient, is everything fine? Yeah, but if you ask the right questions, you can find what issues there are, or how to improve items, medical items, physical functioning items, or prevent issues down the road. So, yeah, it's very important to have specialists involved. And I sometimes will tell medical students, who don't know what physiatry is, that our function, our organ system is function. And so we are experts in all of these different medical problems that limit function and try to improve that function. Yeah, I like that. Thanks.
I think that a key part of being a physiatrist in amputation rehab that we bring to the table is to help people understand that not every person will benefit from a prosthesis. And these are actually the words of Howard Rusk in that JAMA paper. Not everyone will benefit from a prosthesis despite best efforts, and not every type of prosthesis or type of component will benefit every patient. And so when we think about, well, not everyone will benefit from a prosthesis, even the people that do benefit from a prosthesis are not going to be able to use it 100% of the time. So the rehab goals for a patient is always going to include evaluating prosthesis candidacy, optimizing prosthesis function, but in parallel, optimizing non-prosthesis function as well. And the vast majority of other medical team members and patients won't understand that. They'll think, oh, I'm just going to, I'll have this recovery period where I'm healing and then I'm going to get a leg and I'm going to be back to normal, or back to how I was 10 years ago.
When you say non-prosthetic goals for a patient with amputation, what are those details?
So if a person can't use their prosthesis, so let's say if they have a residual limb wound and they need to take some time off from prosthesis use, or they have to get up at night, go to the bathroom quickly, and they don't have time to put a prosthesis on, then how do they get around their home? How do they, how do they go to the bathroom? How do they bathe? How do they get to appointments if they can't use their prosthesis? And can become very challenging because many patients with amputation, especially lower limb, are older and have other comorbidities. So it can be, it's not as simple as just saying, hey, just don't put weight through that leg for a while. It's as you've seen, Yunna, in your experience, it could take weeks of high intensity rehabilitation to train somebody to do those things well, safely, and to identify the right equipment that they need and the home setup that they need to be safe if not using a prosthesis.
I think the hardest thing, honestly, is to say no to a patient, especially with the prosthetic side. It's like, okay, I don't, and I mean, it's such a delicate thing. It's like, one, how do I know? And just looking at them at this setup point. And then the other is, oh, am I doing them a disservice by not allowing them to have it? But at the same time, I'm afraid you're going to hurt yourself and it's not going to be safe for you with a prosthesis. How do you make that? What's an easy kind of, maybe it's not simple, but what's an easy way or a simpler way to for our listeners to understand that?
So I think that in many cases, it's true that you will feel a person is not a good prosthesis candidate, and that it wouldn't be safe, or it just flat out is biomechanically not possible. A lot of those times you can truthfully say, if things change, we'll reconsider this. And here are the things that you could work towards, or that we could work on together to change your prosthesis candidacy, the chances that you'd benefit from a prosthesis. And it's not something that, if someone's never thought about this before, that maybe I won't benefit from a prosthesis, it's probably not going to be one conversation that helps somebody understand that. It might be multiple visits. And so to say that we're happy to talk about this again, we're happy to see you in a couple of weeks, bring your family members who want to ask questions about it. But I find that when that's the case, it's something that we'll have to revisit a lot. And not only for the patient, but to help educate other team members.
I'm interested in, for providers who will rarely see a patient with an amputation, but manage, along with a prosthetist. What are some of the things that you often see that we're not doing correctly or that we're missing?
I think the biggest problem that I see is cases where physiatrists have not been involved in care. So where a surgeon or primary care has written a prescription for a prosthesis, where they don't understand the details and the clinical justification for specific elements of prosthesis componentry. And it's just kind of go to the prosthetist, get your leg, and maybe do some outpatient therapy. So I think, and I have only seen good care from physiatrists that I know in amputation rehab. But so I think where we can help is to make the care related to prosthesis, make sure that it's longitudinal, that we're checking in often, and there if medical problems related to prosthesis use come up. So residual limb problems that maybe are related to the prosthesis, and we can help figure out what they are and how to manage them. So something that I think comes up often is that patients come into their primary care doc and say, I've got a problem with my socket. I need a new socket. And then if we see the patient, ideally with an interdisciplinary team, also with therapists and prosthetists together, we may identify it's not a socket fit problem. It is patients not using their prosthetic fitting socks appropriately, or they're putting their prosthesis on later in the morning, so their residual limb is swelling before they put the prosthesis on. But if they put it on earlier in the day, then the socket would fit fine. Or it may be that it's actually an alignment problem leading to a residual limb wound rather than a socket fit problem. And so that latter one could have really big implications for the cost for the patient. A new socket would be a really big copay. An alignment change is something the prosthetist does fairly quickly, potentially.
Yeah, I see that issue even just with orthotics, where primary care wants to just order a brace, and they order a brace. So yeah, I guess the key is to make sure physiatry is involved in these patients who need the equipment.
And I think it's important for us to understand that prosthetist orthotists have in-depth training on the clinical justification for items. Sometimes I think I see problems with physicians in any specialty not understanding that prosthetist orthotists are experts in clinical care. But what I hear from prosthetists that we work with is that it's helpful for them to have physician collaborators who speak their language. And so they might see something with the patient where they suspect there's a given clinical problem, maybe heterotopic ossification. They can't order x-rays. But so if they partner with somebody who understands, well, what's the significance of that? What's the workup for that or for their new hip pain? Then that benefits the patient, benefits the prosthetist.
I definitely feel that way in my clinic for sure. Having the prosthetist there and the physical therapist there, case management there, seeing the patient together is one, very comforting to me, but also very helpful for the patient overall. I think in residency, I know at Mary Free Bed here, we have a pretty robust amputee program, but what I'm learning is not a lot of programs actually have that overarching amputee education or those opportunities. How do you think, what are your thoughts on how we can improve this? What are some important exposures that our residents could have moving on from becoming an attending?
So I think, back to what I said earlier, I do think of amputation rehab as one of the cornerstones of our field. So first of all, every resident should have clinical exposure, and that doesn't happen. Second of all, it's a complex area of rehab. The prosthetic side of it is difficult to understand. So I put it on par with EMGs. And so for EMGs, residents typically have 6 months of exposure, right? And are learning about it over multiple years and revisiting topics. Whereas for prosthetics, they may have just a few lectures and see maybe 1 month of clinical exposure or once a week clinic here and there. So it feels intimidating, and coupled with lack of exposure, that makes it difficult for residents to see that as part of their practice. But I think the earlier you have exposure and then can come back to it, the more comfortable it starts to be. And I've seen that in practice with if we start exposing residents in their first year of residency, then when they come back through clinic in their second and third years, they're more and more comfortable, feel better about speaking the language, working with prosthetists. So I think another point on education for residents is that I think that they need to hear and have some training in how to apply their knowledge from other areas of rehab to persons with amputation. And it doesn't take a lot of training, actually. It just takes somebody opening their eyes up to say, hey, all of the reasons that you have for thinking that somebody with a stroke or spinal cord injury should come to inpatient rehab, a lot of those translate directly to a person with limb loss, especially if you're thinking about how is this person going to function without a prosthesis for the rest of their life. So imagine you have a patient with a spinal cord injury. It's Brown-Séquard syndrome. It's mainly affected one lower limb. You would have no hesitation to think about admitting that patient in patient rehab. So just translate those thoughts to this person with limb loss.
Oh, I love that analogy. That's like so true. Spinal cord injury or stroke and then amputation. That makes a lot of sense. Yeah.
Yeah, but even more so when you have an amputation plus other injuries, spinal cord injury, stroke. I mean, then it's really complicated, and then you really need physiatry to use all of their knowledge and pull it all together.
That's a great point. So if amputation is due to trauma, then it's usually polytrauma, and there's a lot of other things going on that are complicated and that maybe have not been diagnosed yet because the focus was on saving life and dealing with fractures, but not soft tissue injuries. Or we see patients with plexus injuries that hadn't been picked up, that kind of thing. There are patients with amputation due to peripheral arterial disease or diabetic neuropathy or other severe neuropathy. They often have a lot of things affecting function as well. So maybe their peripheral neuropathy is so dense that it's really impaired their hand function and balance. So they are our patients with limb loss are complex rehab patients. Yeah.
And the rate of reamputation is so high, and the mortality is super high too. I'm just going back to my knowledge of Cucurilla, right?
Yeah.
I think one thing I learned during my fellowship was contralateral limb care. Can you tell our audience a little bit about that too?
Great. So to mention, so there is a really high risk of amputation of the contralateral lower limb in persons who have lower limb loss due to peripheral arterial disease or diabetes related complications. And so there's some great guidelines out there from international working groups, podiatrists, infectious disease, experts that say patients who have high risk of amputation on the contralateral limb, they should be seeing a podiatrist every 3 or 4 months. They should have protective footwear. And so that's often would be just shoes that are extra depth with a wider toe box, and then accommodative foot orthoses. The foot architecture is often changed, so support the foot where it is, what it's changed to reduce pressure on specific points that are prone to ulceration. And so that's something that there are actually physiatrists out there that go more into a wound care and high risk foot care route. So that in some places that could be the appropriate clinic to route your patients to. Often it would be to a podiatry or wound care clinic to make sure they're getting that regular preventive care. And also so that they're linked up with the right person in case they do develop a wound to get it evaluated quickly.
We talked about something earlier that I really want to make sure we have time to get into because I know nothing about it. Yunna said something about osseointegration, and not even sure that's a thing in kids who I treat. So can you tell me something about osseointegration?
Osseointegration is implanting some sort of device directly into bone. And so this field started with dental implants, actually. And in our world, in amputation rehab, there are now implants out there that the implant goes directly into the long bone, and then the prosthesis attaches directly to the implant, which the part that's external to the patient then, rather than using a traditional socket and suspension based connection to the patient. So this has been around for decades now, and it's becoming increasingly available in the US because there's one implant that's been approved by the FDA for use in persons with above knee amputation. So it's available now for more people, and then the other implants that are out there in the US are available sometimes through research protocols for
So
patients.
what are some of the pros and cons of that for a particular patient?
So the pros, the reasons to think about it, the clinical indication is if you have a patient who hasn't been able to use a socket-based prosthesis at all, or it's been really problematic because of socket suspension challenges. So maybe because of the characteristics of their residual limb, due to the morphology of the limb, or say really rapid or severe limb volume fluctuations. Maybe they haven't been able to achieve good socket fit consistently or secure suspension consistently. If you get rid of that socket suspension part of the equation and the prosthesis is just directly attached to the bone, then you don't have to worry about, has my limb changed shape this morning? Is my leg going to fall off if I run, or if I've been sitting for a while and stand up? So it's really great potential for patients with that sort of problem. It's a surgical procedure. So all of the same things that could limit who could get, say, a joint replacement or just any major surgery, that would affect who's a good candidate for this kind of procedure. And so would the patient be at risk for infection or not healing? Are they under the weight limit for a given device? Those are all considerations in terms of who could actually get the procedure. And then I think cons potentially. So downsides are that an implant there may be lifelong precautions. So don't swim in stagnant pools of water or pools. No high impact activities. A lot of people want to run. So if they can't run again, that might be a thing that would make them not want to pursue the treatment. Having to avoid activities with a lot of torsion is another potential lifelong precaution. Um, Essentially, osseointegration is creating an open wound, a chronic open wound. So there's daily maintenance that a patient has to do to prevent complications. And even with best care, they may have complications such as infection that may even require explantation or revision of the residual limb to a shorter length. And if that happens, then it could be even harder for them to use a traditional prosthesis.
What's the recovery process like after the surgery? Do you get to use it immediately, or is it a prolonged course that you need rehab?
So it will depend on the specific implant. They have differences. Some are one surgical procedure, sometimes it's two, but there will be some healing period after a surgery where there's no prosthesis use, can't use the old prosthesis, not ready to use a new prosthesis yet. And then that phase is actually, that takes us back to how do you get around without a prosthesis? And that's part of the candidacy question for osseointegration is, could this person live their life, do what they need to do while they're in the healing phase and in the working up towards using a prosthesis again phase? So then there are specific rehab protocols for activities that a person should be doing in preparation for initiation of weight bearing through the limb that had the procedure done, progression of weight bearing, and then initiation of prosthesis use and progression with prosthesis use.
So my thought process is that it'll be more common in above knee amputee patients compared to below knee amputee.
That's so yes for now, because it's only in above knee patients that there's FDA approval.
Got it.
For an implant.
And I'm sure it's not FDA approved for kids because we always lag behind. I'm wondering if it would make sense if anybody is doing it in kids, or if it would make sense. I think they probably tend not to have those limb fluctuations in volume. So maybe it's going to rarely make sense.
Also,
that's a great question. I don't know of research in that area, but there may be some.
Yeah. Also, like growing and cortical thickening, maybe.
Yeah. Hypertrophic bone formation.
Yeah.
Basically, when we do adult amputee care, I feel like there's two larger categories. Of course, there's in between like dysarticulation levels, but it's mostly below knee amputation, I think, is the highest number of patients I see, and then above knee amputation. So what are the main different things to think about, and why is it so much harder for above knee amputees why is there so much higher energy expenditure for them?
Great question. So what I like to tell patients is if you have an above knee amputation or knee dysarticulation, as you pointed out, it's really a completely different ballgame when it comes to prosthesis use. And for a person with a below knee amputation, I like to think of it as often using a prosthesis is going to work out. And we're really we're looking for things that might tell us it's not going to work well. Whereas we flip it, for somebody with an above knee amputation, there's certain things that a person has to be able to do for it to even be physically possible to use an above knee prosthesis. So it's really like we're looking for these specific things that put using a prosthesis on the table, and then we can talk about it. And the key thing for people to know is that with the technology that's out there, an above knee prosthesis is not going to help you stand up. It's not going to help you go from the sitting position to standing. So sit to stand transfer. Caveat, there are now some knees that are powered on the market. Those are not appropriate for most patients, and from my understanding, would be very difficult to get covered by insurance. And even if they were easy to get, they're super heavy, which is really not ideal for the initial prosthesis for a lot of patients. So if the knee can't stand you up, then how you stand up, how you get to standing, it's all your other leg that does the work. So in rehab terms, a person needs to be modified independent and sit to stand transfers, and not just I'm saving up all of my energy to do it in our interdisciplinary clinic visit to show you that I can get a prosthesis, but doing it all day long as often as you would do if you were regularly walking. And here, so that we need to explain this to patients, but what I see a lot of times too is that the rest of the team, even people who should know that you have to do a sit to stand transfer in order to walk, people get so excited about the idea of walking with a prosthesis that they forget that element of it. So when we talked about non-prosthesis goals, and that it's really important to think about just for lifelong getting around without a prosthesis for anybody. But for somebody with an above knee amputation, we can further explain the more you do without a prosthesis, the better chance you're giving yourself of actually being able to use a prosthesis. And then what we can explain to patients and the rest of the team is that after that initial post-amputation rehabilitation, often where patients start at is working on wheelchair level mobility for a while, especially our older patients with comorbidities. But we want to, as physiatrists, encourage them, let's achieve that. Then let's keep going towards working on standing upright. So mobility where you're standing upright with a single lower limb. So that could be with a walker, sometimes with forearm crutches, or even if a patient's just working on that in the parallel bars, working on activities, say with occupational therapy, instead of grooming from the wheelchair, working on getting up to standing at a sink and doing grooming, and working on dynamic balance, reaching for things while standing with one leg. All of that then will make them much better candidates for an above knee prosthesis. But so if a person can't do all those things, if they can't stand up just with their other leg, if they can't remain standing for 5 to 10 minutes so the prosthetist could take a cast for prosthesis and then work on fitting for the prosthesis, if they don't have the neuromuscular control to move around some while upright on one lower limb, then they're not going to benefit from an above knee prosthesis. And like, literally for some patients, it's true that it just would not be physically possible for them to use an above knee prosthesis at wherever they're at right now. Other things that make it really difficult, the socket for an above knee prosthesis, it comes up really high. So it comes into the groin. There, the traditional socket, or most commonly used sockets, an ischial containment socket. So it's inside the ischium, containing the ischium from the inside, outside the greater trochanter. So that's very uncomfortable in sitting. It's uncomfortable in standing too. The edge of the socket is typically flared in some parts to make it better tolerated. But so with that flared brim and how high the socket comes up, then that makes it very difficult to don the prosthesis while in a seated position. Whereas a person with transtibial amputation, they can initiate their prosthesis donning while seated and usually get pretty secure in the prosthesis before they stand up. Person with an above knee prosthesis, hopefully they can get the prosthesis on a little bit, enough that it will sort of stay on while they stand up. But then while they stand up, they can't put any weight through it because the knee will collapse, B, it's maybe not on securely, so it could come off. And then once they've stood up, they need to remain standing while keeping all their weight through their other leg. Now they're reaching down to secure the prosthesis, so to tighten up the lanyard strap or to get all the way seated into the socket so that now they've got their negative pressure suspension, their suction in effect. And they can't put weight through the knee until they're securely seated in the socket and the suspensions and functioning. So that's really complicated. It's a lot to think about. It takes good balance and neuromuscular control to be able to do all those things. Whereas imagine a person with a below knee amputation who has a pin locking suspension, they're seated, they put their residual limb in the prosthesis after donning their liner. Once they've gotten to be pretty good at it, if they hear a couple of clicks when they're seated, they know they're good to go. They're going to stand up, get a few more clicks, and that's a pretty secure then that complicated sit to stand transfer. Not so complicated for transtibial. For a person with transfemoral amputation is complicated. I think so. Other things with transfemoral amputation that make it a whole different ballgame. You brought up the energy expenditure aspect of it. So walking with a transfemoral prosthesis, there's research out there that shows it is a higher energy expenditure. And if you think of it from a cardiac workload perspective, so for below knee amputation, generally a person can walk slower to allow their heart to meet what's demanded of them in walking with a prosthesis. For some persons with an above knee amputation, there's a threshold such that the cardiac work required to walk, they just can't get above that threshold. And so maybe that's something that's modifiable with cardiac rehab or other kinds of rehab, but it's I think how we see that in practice would be a patient who's been fitted with an above knee prosthesis and they just tire out with a little bit of prosthesis use and can kind of never get over that hump, or they have dyspnea with a little bit of prosthesis use.
Fantastic. I think that's very helpful for me. Going into this, I'm thinking, there's different components and, what knee, what foot. And I think all of that just pales in comparison to what you just talked about this whole time, kind of the functional implications and who could benefit from a prosthesis and why would they benefit and what issues may come up. So I appreciate all that.
So you don't have to know very much at all about how prosthetic knees work to be able to help patients and the rest of the team shift their focus and see things through a different lens.
Focus on function.
That's what we do. What are some things, because you're in the world of amputee rehab, that you look out 5 to 10 years? Like, this is the next big thing. Like, what are some exciting things that you see?
So developments that would really help a lot of patients. I think anytime things become lighter, that's great. Work has been done or is being done to increase the modifiability or flexibility of sockets to accommodate volume changes or improve comfort. That can really help. So there are a fair number of patients who the volume fluctuations, as we talked about when we were talking about osseointegration, residual limb volume fluctuations might mean they never can achieve good socket fit. And so on a given day, I can't fit into my prosthesis, or I'm just swimming in the socket. It's not safe to use the prosthesis. And so addressing that could help a lot of folks. When it comes to powered componentry, so there are now some powered knees in the market, as we said, not suitable for everyone. So if the weight of those comes down, if they work well for a larger section of patients, then someday, so I'd love it if in 10 or 20 years, our patient who's very low mobility, who has severe osteoarthritis on their contralateral knee or hip, so they can't do single limb sit to stand transfers, if there is a powered knee, that could help them stand up and would work for them, given all their comorbidities and so forth. There's a lot of research being done into improving communication and control of a prosthesis, so neural interfaces, for example. A lot of that's more in the upper limb amputation world, but that has a lot of great potential, both in upper limb and lower limb.
I know a lot of my friends are working on this legislation. And it's not, there are a few states that are approved. And I love whoever named this thing. So every body can move. I think that's such an amazing name. I absolutely love it. Kudos, whoever you did it. But can you tell us a little bit more about that?
So I don't have personal experience with trying to get this legislation passed or anything. But so it is an effort to get insurance companies to cover prostheses and custom orthoses to do a better job of covering. Traditionally, it's very difficult to impossible to get a second prosthesis for someone, for example, or even to get a new socket when clinically indicated or a new prosthesis when clinically indicated. And so I'm actually, the paper that I pulled is the Washington State bill that passed recently, because it had some language in it that I really, really loved. Um, so it phrased things, or part of it phrased things as, if insurance would cover a surgical procedure or other medical intervention to help a patient achieve XYZ activity, then the insurance company should be covering the custom orthosis or the prosthesis to help the patient achieve that activity. And I love that way of thinking about it. I think also it's helpful to think, so sometimes more prostheses is more problems, and that to get a single fitting prosthesis to work well, that it can be a lot of visits with the prosthetist, a lot of training. And even when you add one additional into the mix, then it could be, okay, now you're troubleshooting two sockets. Or if you need a new socket, well, should you be getting two new sockets? So even if it becomes easier to get a second prosthesis, I would still encourage people to think about, well, how could we use this one prosthesis to meet as many needs as possible for a patient? But yeah, there's many potential clinical indications for a second prosthesis. It could be sports, or other activity related goals, hiking, yard work. It could be occupation related goals. So maybe the work environment has a lot of stairs or has exposure, water exposure. But also it could be things like a prosthesis for somebody to use in the shower. So shower leg, we say. That could really improve somebody's safety, potentially their ability to bathe independently.
I never thought about that. That's amazing. Yeah, because when we shower, I mean, I myself personally feel like I'm going to fall almost every time coming out of the shower. Maybe we should be concerned about it, but it's like, it's so slippery, right? There's so many things. The towel's there. It's a tiny place. Normally the tubs are really high. So yeah, I think that makes a lot of sense.
Although, I believe you have thought about that before.
I know I
In
did.
fact, during fellowship.
Yes, we did. I got called out there.
Okay.
So I think one of the things that I talked about you before I started my fellowship was, a lot of people, when I said I wanted to go into amputee rehab, they were like, oh, you don't have to do a fellowship. You can just go straight out of residency. And I remember sitting at AAP and having that conversation with you. Like, I don't feel ready to just go straight into attendingship, making like proper care for amputee patients, and what are the reasons, and what does the fellowship look like? And I personally, I'm so grateful I went through that entire year, because I've learned so much. Like, you just don't know what you don't know in the end. So can you tell us a little bit about the fellowship?
Yeah, I think so. So different fellowship programs will differ in their exact clinical exposure and curriculum. I think the biggest reason to do a fellowship in amputation rehab is to get more clinical exposure. And if you do a fellowship at a site that has a large patient population, then you'll have a lot of clinical opportunities, outpatient, inpatient, a lot of different types of patients to see. And so, for example, upper limb amputation, it's more rare. A resident, if they've rotated through clinic a few times, they're lucky if they've seen one person with upper limb amputation. If you do a 1-year fellowship at a program with a big population, you'll have seen quite a few people. And maybe in 1 year, you'll see more people with upper limb amputation than someone who's never done a fellowship will see in 10 years or their entire practice, potentially. So just seeing the patients, getting that clinical exposure is great. But also part of that clinical exposure is working with experts, the physiatrists, prosthetists, therapists, nurse case managers with a lot of experience in this area. I like to think of it as so one of my other loves is evidence-based practice. And one of the founders of evidence-based practice said there's 3 pillars to evidence-based practice. The first is the evidence base, the research evidence. The second is clinical experience. That's as important. You capture things, you learn things from clinical experience that research can't tell you. The third pillar is patient's goals and having the patient as part of the team. But so then when it comes to that second pillar, to gain your own experience is invaluable. But if you're working with a big team that themselves has a lot of experience, then that's even more, you're getting secondary experience. And so Yunna knows from fellowship that we would talk through patients that the fellows haven't seen, that I've seen. Or if you as a fellow ask a prosthetist what they think about a given patient, now you're learning from them what they learned in school about their clinical experience. They'll probably tell you about some patients that they saw that are interesting and related. So really expanding the knowledge base. And I think it's so understanding how prostheses work is really, really difficult. As we said, it's rare for residents to get enough exposure to feel really confident. I think the amount of exposure that you get in fellowship can take you to that level of, okay, I think I could competently come up with a specific prescription for a prosthesis. And I don't advocate that doctors should be doing that by themselves. They should be working towards a prosthesis prescription as part of a team. But the better you get at that, then the more equipped you are to be and to help make informed decisions, but also to help provide ideas, whether it's for the first prosthesis or if something is not working out. The more ideas you can have for troubleshooting, the better. And then the more we as physicians understand, the better we are at giving the clinical justification for a prosthesis or component, which then is going to impact whether it actually gets covered for the patient or not.
So you learned a lot in your fellowship, I can tell. Even though you should have done a pediatric fellowship.
Oh my gosh, here we go. Well, full disclosure, Dr. Speckman was like, maybe you should, after this fellowship, go do a PEDS fellowship.
Right?
And my fiance was like, no, we're going to make some money now.
So I think a misconception people have about amputation rehab fellowships is they think that, well, if you do that fellowship, then you'd have to do only amputation rehab. And are you going to find a job where that's all you would do? And I think I get it. I probably had that thought at some point, but we don't think that about SCI fellowships, right? A lot of people do an SCI fellowship and then they do general inpatient rehab or outpatient, and they've just got extra expertise in working with patients with SCI.
For sure.
Good. Well, I want to thank you so much for joining us and teaching all of us so much about amputee care. I think this has been very helpful, certainly for me, and I think our listeners as well.
Absolutely. Thank you so much, Becky.
Thank you, Doug and Yunna.
So, Doug, I'm curious to hear what you thought. Obviously, this is my passion. So what were you?
And I understand why it's your passion. It's very interesting. And what I really liked out of this discussion was the kind of in-depth discussion about all the functional implications of amputee care, like who does it make sense to have a prosthesis and who doesn't? What do you do when your prosthesis is in the shop or you're healing a wound or something? And there's just a lot of thought that goes into that I don't really think about because I don't see these patients. So it's been very helpful for me.
Yeah, for me too. It's always I find it the hardest thing to say, no for prosthesis for patients. And it honestly doesn't really happen often. Majority of our patients do benefit from prosthesis. But when I have those really tough conversations over multiple visits, I think today's discussion was really helpful for me to see like, how do I balance this? How do I encourage them to get better to the point that they would eventually benefit from a prosthesis, but in a safe manner?
We want to hear from you. What questions do you have about amputation care in general, or maybe specific topics in amputation care, such as targeted muscle reinnervation, osseointegration, other topics?
So join the conversation, share your thoughts in the comments below, or connect with us on our social media platforms. And we cannot wait to hear from you. You've been listening to The Summary, a podcast from Mary Free Bed. I'm your host, Dr. Yunna Sinskey.
And I'm Doug Henry. Don't forget to like, comment, subscribe wherever you get your podcasts.